So here's a review of the present technologies in the field. Radio frequency is kind of my thing. I have done a lot with radio frequency. Cryolipolysis has been super popular, ultrasound, and lasers. And all of these technologies are thermal, and they primarily address subcutaneous fat. There's no real effect on muscle, and not really too much of an effect on skin. So what are these devices missing? And I think they're missing a fact that there are many other things to address besides just fat. 16% of your body weight is skin, 25% is fat, and a full 35% is muscle. And muscle is the one thing that's often overlooked. So when we're looking at the Emsculpt NEO, we're looking for a desired response, not only in any adipose tissue, but in the muscle. This is an SEM that I've done. I'm kind of a nerd about SEM. I love it. And there's several ways for this adipocyte to be eliminated without surgery. Apoptosis is the way that, or programmed cell death is the way that the original traditional Emsculpt works. But when radiofrequency is added, the process of electroporation comes into play, and this really accelerates cell lysis without causing undue inflammation. Next. So the ideal muscle, no, back up, sorry. The ideal muscle response, this is a slide taken from my veterinary study on a porcine model showing the original musculature before treatment and a cross-section of muscle after HIFEM. And you don't need to be a pathologist to see that there's quite a bit of muscle hypertrophy and even a little bit of hyperplasia or new muscle growth. The ideal skin response, you can see on the right, takes an H&E skin biopsy that's a little bit on the purple side, not so much collagen, and creates an abundance of dense collagen with quite a bit of neoangiogenesis. So BTL has over 27 years of innovation, but they have taken an exponential leap in innovation over the past couple of years. They've created a whole new category in the aesthetic field, and I think they've been first to market with a non-invasive technology that goes quite a bit beyond fat. It's basically a core-to-floor treatment and can address areas in the buttocks, the abdomen, arms, calves, pelvic floor, and as well as skin. So here's a technology overview of the electromagnetic spectrum. And this is really interesting because I don't think a lot of people really get that radiofrequency is part of that spectrum. So a range of frequencies of the electromagnetic waves, if we're looking at terahertz, this is our visible light spectrum. The radio frequency is high frequency, and most commonly, while the non-invasive devices range from 1 to 30 megahertz, the subdermal devices, and I have a whole lot of experience with these, are about 1 to 3 megahertz. When we're looking at the very low frequency, or HIFEM, then these are about 3 to 30 kilohertz. They don't really interact much with tissue. Go ahead. So when we're looking at HIFEM on the electromagnetic spectrum, we have a really long wavelength, but the energy is low. And the safety aspect of this is that the energy of these waves is really not absorbed by the tissue, and therefore it doesn't really cause thermal effects. It's more of a mechanical effect. So the electromagnetic waves pass through the tissue and induce some secondary currents, and they're primarily concentrated in the muscle, then a little bit in the overlying fat, and then a little bit of an effect on the skin as well. Next. So HIFEM, basically, we're looking at Faraday's law, and Faraday's law of electromagnetic induction shows that a changing magnetic field is the key to producing a secondary electric effect or currents within the tissue. It's basically a photon-based treatment. So in a single treatment, HIFEM makes thousands of electrical pulses, and these are induced supramaximal contractions that you cannot voluntarily produce in the gym. These trigger muscle contractions, and you're going to get a lot of muscle contractions in a single 30-minute session that would be impossible for you to reproduce. So when looking at voluntary muscle contraction, these are basically neural impulses created by your brain. Your brain creates an action potential, which goes into the muscle and creates a contraction. This is a great slide because it shows on the left what you can do with your brain. Not a lot of muscle recruitment, even when you're exercising really hard. But HIFEM really induces 90 to 100% of your muscle fibers, and you're getting a whole lot better workout in a very focused area. And this is how you get such great muscle hypertrophy. Now, I have a lot of patients who come in and say, hey, doctor, okay, it's electromagnetic stimulation. So I could buy online a TENS unit, say, for 150 bucks. And if I use that, then I could get all sorts of treatment for less than the cost of a single Emsculpt. So why don't I just use a TENS? Well, it's interesting because TENS units, you'd have to use them for 60 minutes a day for 90 days to get any muscle hypertrophy at all. And it's not going to be nearly what you get with Emsculpt. So the limitations are that it's a direct electrical current. It's not really an oscillating low frequency wave. So it finds the shortest path between the electrodes. That way, it only concentrates in your superficial layers, and it doesn't really engage all of the muscle like Emsculpt or HIFEM does. So the muscle stimulation in HIFEM is really concentrated in the belly of the muscle, in the body of the muscle. You're going to see a little bit of overlying fat involvement, and in the devices such as Emtone and Emsculpt NEO, those devices that have a little bit of radio frequency, you'll also get some skin response. So here's where radio frequency sits on the electromagnetic spectrum, and this is in the higher frequency range. Like I said, on the average, 1 to 3 megahertz, although there's some that are higher and some that are lower. But there's really no motor response, no muscle response to these, because the waves induce friction within the tissue, and the oscillation causes a thermal response, but you're not going to get any depolarization of the muscle and no muscle contraction with RF. So how does radio frequency work? It's pretty simple. We know that opposites attract and likes repel. So the molecules are going to be oscillating within the tissue that is directly stimulated with radio frequency. So radio frequency basically depends on your size of your applicator. If you have an applicator like this, then the depth of your response is going to be about 50% of the diameter of your electrode. So for most, unless you have a giant applicator, it's not going to go very deep, and it will stay at the level of skin and fat. So RF heating distribution in the human body, you should know that in order to optimize your RF response, you really need to have well-hydrated tissues, because fat has a resistivity that's really pretty high. Dry skin doesn't really accept radio frequency energy either. And muscle is too deep to really be directly affected by radio frequency. And so while more heat is created in the fat than in the skin or the muscle, because of its lower conductivity, you're going to see most of your reactivity to radio frequency within the adipose layer. So here's a great question, because it hasn't been done before, ever. Can radio frequency and HIFEM be applied together? And normally these guys do not play well together. RF electrodes are made out of metal, and metal objects don't do well with HIFEM because they get heated up and then you could get a burn. So the engineers at BTL have come up with a novel way to make RF and HIFEM be simultaneously, not sequentially, applied. So the way they've done this is they've created what they call a novel synchrode RF electrode. And what this really is, it's not a single applicator. It's 112 segments in each treatment head. And they are interspersed, they're very tiny, and they're interspersed between the magnetic fields so that the energy can be simultaneously applied. So if you look on the left, the magnetic fields and solid electrodes don't play well together because the electromagnetic field does not get beyond the RF, and the RF doesn't get beyond the electromagnetic field due to eddy current production. So if you're looking at the synchrode RF, then you can get, with really precise interspacing, then the electrodes are transparent for the magnetic fields and the magnetic field can get through. So this is a great innovation because it still preserves that 30-minute optimal treatment time. That for me is about the maximum time that my patients will tolerate sitting there without doing anything before they start to get bored, right? But you're getting RF and HIFEM at the same time in a single 30-minute treatment. So here's the thermal profile of RF and HIFEM. The skin gets to about 42 degrees, at which you're going to see some generation of dermal collagen deposition and some dermal thickening, actually. With the fatty area, you're going to get to 43 to 45 degrees centigrade, which will cause some lipolysis, and combined with the HIFEM mechanical stimulation, then you'll go on to get some electroporation, which really optimizes fat loss and diminishment of the thickening of the fat layer. At 40 to 41 degrees centigrade, you will get optimization of blood flow because this is a vasodilating type mechanism. And then, of course, this primes the HIFEM to work better to induce muscle hypertrophy. So the effect on the adipose tissue has been measured, temperature over time, and found to be very, very stable up through the end of the 30-minute treatment. And you'll see it reach its target temperature within the first 4 minutes. Effects on adipose tissue are really a little bit more complex than that of the original Emsculpt or any of the other competing devices out there. So you're going to see some egress of free fatty acids, triglycerides, and glycerol, and this will lead to programmed cell death. But also incorporating the HIFEM, you're going to see mechanical induction of electroporation. And we'll talk about that more in a little bit. So the effects on muscle tissue are similar to adipose. You will see that the muscle temperature is reached within 2 to 4 minutes of the beginning of the treatment and is sustained throughout the course of the or duration of the treatment. The benefits of muscle heating: you have an enhanced blood supply or optimized, basically, vasodilation, which better delivers the oxygen and micronutrients, and heat shock proteins are then expressed, causing muscle increase, and also this is also caused by the HIFEM directly as well. So the biggest benefit, I think, of muscle heating, along with the HIFEM energy, is that you're going to get a whole lot faster results with exercise. I know a lot of us try to exercise. In Colorado, it's kind of almost a religion. If you don't get your workout done that day, then it's a bad day. But not all of us can do that. We're busy. We don't have time. The gyms are closing, or at least they're at 10% or very reduced capacity. So we can't really always go to the gym. But the great thing about Emsculpt NEO is that you can get a tissue response equivalent to 12 to 16 weeks of an organized resistance training program. So 4 weeks or 4 months. I'd take 4 weeks. The NEO is FDA cleared for non-invasive lipolysis or breakdown of fat in the abdomen and reduction of circumference in the abdomen with skin type 1 to skin type 3. I'm currently doing an FDA level study for the company on inner thighs, and we're incorporating all skin types types 1 through 6, to show that it is indeed safe for everyone. We're well underway, and so far we've had absolutely no problem with the darker skin types. We also see improvement of abdominal tone, as well as improvement in muscle tone in the arms, buttocks, legs, calves, and abdomen. So what does this mean for your patients? It's all well and good to have this theoretical understanding, but 30% less fat with the Emsculpt NEO, with a 19% traditional response with the Emsculpt. Regular Emsculpt, 15.8% more muscle. With the NEO, 25% more muscle. With the regular Emsculpt, there was a measured 11% reduction in diastasis recti, or abdominal muscle separation. And with the NEO, it's up to 19%. You can get just under 6 centimeters of waist circumference reduction with the Emsculpt NEO. So here's some clinical cases of the Emsculpt NEO, and these were all done during the studies, basically during the FDA clinical trial phase. So Bruce Katz, nice results. Next. You can see some great results. And the nice thing about Emsculpt is that it's not operator dependent. I learned how to do fat grafting from Sid Coleman, and he was the only one at the time who could get good results. But here we show that pretty much everybody who turns the device on can get some really significant improvement with the Emsculpt NEO in the abdominal region. You can see increased muscle tone, especially in these two particular slides, as well as decreased the abdominal protrusion due to the diastasis, and some significant fat reduction as well.
Doctor, real quick, if I can jump in, there's a question asking, how do you apply the Emsculpt to some of your surgical procedures, or combine the two together?
So I had a patient today who came in and wanted to know, at first I thought she was going to get an abdominoplasty because her friend had had one with me a couple of years ago and was very happy. And then she diastasis. And so today we talked about optimal outcomes with non-surgical approach being a combination of Emsculpt NEO, because I like to address the foundation. And if you do a tummy tuck, you're not really getting muscle hypertrophy. You are correcting the diastasis, but you're not really setting up the foundation for a strong core the way you are with the Emsculpt. So even in patients who are getting abdominoplasty, I generally start them out with Emsculpt in order to get their foundation toned, so to speak.
Very good. Thank you.
So here's some results from Radina Denkova, and she did some of the very earliest work when the Emsculpt NEO was a prototype, and so you'll be seeing more from her. I love working with David Kent. David always has a way to optimize outcomes, and you'll see a really great result from his coming up. Here's some really pretty amazing buttock enhancements from the Seaside and Lasky clinics. Much better than fat grafting for me. I don't do fat grafting of the buttocks anymore. I just put them on Emsculpt. So some of the previous clinical investigations on Emsculpt, there were 30 studies done between 2018 and now, including MRI, CAT scan, ultrasound studies of reduction of fat thickness and increase in muscle hypertrophy. Go ahead. So this is a little mini study not published of mine, in which I had a 63-year-old patient that I did some 3D and 2D evaluations on, and Canfield was kind enough to process these. So this is a patient where I really wanted to optimize the outcome. She's a busy lady, wanted some reduction in her diastasis, had tried everything, personal training, and I treated her over a 6 months period of time with 6 rather than 4 traditional Emsculpt treatments. And so you can see the ghosted image of the volumetric loss. And this is really significant. This is probably a little more than you might get with liposuction in this woman, because she got not only fat reduction, but muscle toning, and a really nice reduction of her diastasis recti. I haven't seen up till now a volumetric calculation of volume loss with Emsculpt. So Roland Reed at Canfield is a friend of mine, and he volunteered to do this volumetric study using vector technology to show not only the overall volume reduction of over 1,000 cc's, but where the volumetric reduction is the most significant. And of course, you wouldn't be surprised to see it in the region of the rectus muscle and reduction of diastasis recti. And this is another important area that I think that we probably should look into further. How much skin surface area reduction can you get with Emsculpt? I know Barry DiBernardo wrote an article in ASJ in 2013 talking about skin surface area contraction with laser-assisted or smart lipo, and he got about 13%. I think Bruce Katz got up to 17% skin surface area reduction. And I wrote an article in 2014 in the ASJ noting that subdermal radiofrequency, you could get up to 26% skin surface area reduction. But of course, these are minimally invasive. So if you can, Mike, can you go back just a minute? And I was really surprised to see that with Emsculpt, you can get 17.5% skin surface area contraction as a nice beneficial side effect of Emsculpt. So some more of the studies, I did a veterinary histology study that was published in ASJ in 2018 that showed that you got quite a bit of muscle fiber hypertrophy and about 7% hyperplasia. Well, what's the difference between hypertrophy and hyperplasia? Well, hypertrophy means the muscle bundles itself is a little bit thicker and you have thicker fibers. But with hyperplasia, you have absolutely you're developing new muscle fibers that are generated from stem cells. And then we have some more studies on long-term effects. Dr. Halas did a really nice study on the fat physiology of Emsculpt. And many more of my colleagues have reviewed non-invasive body contouring devices with fat reduction and quantification of muscle hypertrophy with CAT scans, MRIs, and ultrasound. And interestingly, with these three modalities, all of their numbers came in pretty close to each other. We have some peer-reviewed publications that round out the Emsculpt original cadre of studies. And it's interesting that all of these, there are 30 studies that were published within a 2-year period. And this is really unparalleled for any other device. So here's some clinical studies with the Emsculpt NEO. There have been 7 studies to date that have been completed and many more in the works, 30 investigators. And here are the numbers again: 30% fat reduction, 25% muscle growth, which is huge, and 19% improvement of abdominal separation. So Radina Denkova did some of the very first work on this device when it was a prototype. Her first study showed 8 clinical and histological evaluation of 8 patients. And go ahead and progress. And these 8 patients had biopsies at the baseline and then anywhere from 10 to 90 days post-treatment. These were stained with H&Es, and they used 2 different pathologists to basically verify any changes in subcutaneous tissue or damages of overlying skin. So there's a fairly repetitive progression seen in the Emsculpt NEO. You're going to see non-invasive lipolysis or egress of little lipid droplets containing triglycerides and glycerol anywhere from the first 10 days, peaking at 20 days. You'll see intensive fat cell disruption or membrane disruption. And then there's no damage to the overlying skin, sweat, or sebaceous glands, like you can see, say, with Kybella injections. And then you see over time, let's say, at a month or so, deformed nuclei and pycnotic nuclei indicating cell death along with the cell membrane eruption. But at between 2 and 3 months, you'll see stabilization of the tissue. The macrophages will come in and clean up the dead cells, and the tissue has recovered.
So, doctor, from one of your previous slides, someone just wanted to clarify that Emsculpt is causing both hyperplasia as well as hypertrophy of the muscle.
Absolutely. If whoever asked the question wants a copy of the article, I'm sure that we can get it to them. And we have an upcoming study that Dr. Halas and I did that shows the stem cell quantification using immunofluorescent staining. So the answer to your question would be yes, both of them. And so here are some histologic changes. You can see a baseline, all the cell membranes are intact, and 20 days after, this is when you'll see a peak in disruption of cell membranes. Here's another study from Dr. Denkova talking about the effect of the prototype device for lipolysis and circumference reduction. And this was a 42-patient study, including 13 men, using some ultrasound imaging to measure the decrease in fat, as well as waistline circumference, and the standard with all our BTL studies, a patient satisfaction survey, and a therapy comfort survey as well. So ultrasound imaging showed ongoing improvement of the results over time, even though there was a cessation of treatments after treatment number 4. And the results peaked at 3 months with just under 30% fat reduction as measured by ultrasound thickness. She also saw that 88.1% patients were satisfied with their treatment outcomes, and over 90% found the treatments comfortable. And I think this is really important. When I first got Ulthera, the Ulthera worked really well, but it was so painful that patients would rarely sign up for a second treatment. Same thing with HIFU. It's not extremely efficacy is not really great, but you couldn't even get people to sign up for it because they heard it was so uncomfortable. So the great thing about all of the BTL treatments is that patient comfort is optimized. My colleague Julian Samuels, along with Bruce Katz and Bob Weiss, did a study that talked about the simultaneous aspect of the RF and HIFEM. This was one of the really great, well-designed studies because it was a sham-controlled randomized trial. The study design was excellent because there were 72 subjects, and they were divided into the active and sham groups, a few more active than sham, with very similar age distributions and BMI. These patients both had 3 treatments on the abdomen once a week, and the intensity of the sham group was only set to 5%, so all the parameters were similar except for the treatment intensity.
Doctor, really quick, back to the Neo. What is one of the questions is, what is the maximum BMI, or what is the target BMI for the Neo?
Well, the device is only cleared to treat patients with a BMI up to 30. But this is, especially for many areas of the country, say in the Deep South and the Midwest, the average BMI is quite a bit higher, say, than here in Colorado. But I think that's a great question, because what do you have to offer your patients who have a BMI, say, of 35? Yes, it is off-label, and we would have to divulge that, but I think that using the Emsculpt NEO would be a great place to start, because in the past, patients have come in with a BMI, say, of even 40, and I have nothing to offer them except to tell them, go home and lose weight. Well, they hear that everywhere, and that's not really motivating. But I think if you wanted to start treating them with the Emsculpt NEO while they're achieving the optimal BMI for, say, either liposuction or abdominoplasty, this is a really great option for a market that has been, before now, really kind of unaddressed. Next slide. Mike?
Yep, it advanced on my screen. Let me see. You there? Do you see it?
Yeah, thank you. So ultrasound imaging with this particular study showed fat reduction in the active group, but not in the sham group. The fat aspect stayed pretty stable. And looking at the muscle group, you can see progressive thickening or increase in muscle mass in the active group, as delineated by the blue bars, and a pretty stable maintenance of muscle in the sham group. The changes were really insignificant at 1 and 3 months. So the other things that Juline's group found in the study is that the treatments were comfortable. Quite a few of the A group had improved appearance. The patients of the sham group, of course, didn't really see anything, and skin type didn't really matter. So if we're looking at examples of patient results, you can see on the before on the left, the patient had quite a thick fat pad, 2.73 centimeters, and lost almost a centimeter of fat pad thickness after 3 months of after the Emsculpt treatment. Another person, age 51, lost a little bit less, but still quite significant 3 months after the Emsculpt NEO treatment. Here's some examples of patient results, and you can see, as well as some fat loss and muscle toning, a pretty significant improvement in the diastasis recti. So their conclusion was that the procedure combining RF and HIFEM was very effective for abdominal body shaping, and of course there was no response in the sham group. The next study we'd like to review is Carolyn Jacob, David Kent, and Dr. Ibrahim, and they were looking at the application of HIFEM and radiofrequency for abdominal fat reduction and muscle toning, and they used MRI for their evaluations. They had 40 patients. Average age was 39.1, and these were 3 treatments as well, once a week for 30 minutes apiece. Next. Their evaluation methodology was primarily MRI imaging underneath the umbilicus and just above it, looking at fat thickness, muscle thickness, and the diastasis recti. They also looked at waist circumference and satisfaction and therapy comfort. Next. So their results showed the average reduction of fat across the abdomen was 24.4% at 1 month and 30.8% at 3 months. And it's really interesting because patients love something that has ongoing result with no ongoing treatment. And so continuing improvement is a really big selling point for me. At 6 months, their fat reduction had stabilized at about 28%. Results with the muscle tissue showed an improvement of diastasis recti at 16.7% and 23.5% at in muscle thickness. At 3 months, the abdominal muscle separation had improved by 18.8%, muscle by 26%, and the peak of the diastasis recti improvement was at 6 months, 19.8%, and muscle thickness improvement was 25.3%. And I know Carolyn has a real interest in this because she had twins, so she's been having quite a bit of Emsculpt to improve her diastasis. Waist circumference reduction was 3.3% centimeters, 5.9% at 3 months, and up to 6.7 at 6 months, which I think is an amazing result. All the treatments were comfortable. Patients were happy at a 90 to 97% rate. And here's some really excellent MRI slices showing before fat thickness, diastasis, and muscle. And you can see the pretty significant changes in the before and after in these slices. Here's subject number 5, before, 3 months after. You can see really significant improvement in muscle character and quite a bit of loss in abdominal diastasis. And a lot of us don't really look at this in gentlemen. You know, we don't even really think about it, but that abdominal protrusion that we might surmise is only visceral fat can be a muscle gap as well. So their conclusion was, of course, that there was significant fat reduction and muscle thickening. Their numbers were great. And I'd like to kind of interject here that my friend Brian Kinney did a study that was just recently published on visceral fat. And he found it was a retrospective study of a lot of patients who had had an MRI evaluation after original Emsculpt, and visceral fat reduction was 14.1%, which is really pretty significant. And this was basically just a side effect of the HIFEM, which was targeting muscle. Bob Weiss did a wonderful study on with SEM on HIFEM and synchronized radiofrequency using porcine model. So the study design was 7 large white pigs. They received active treatment 3 times 30 minutes, so once a week for 3 weeks. And then biopsy specimens were taken. I was taken to task when I presented the porcine study at ASLMS because there were only 4 pigs in our study and only 7 in this study. But there were 200 samples of tissue in my study and 252 slices in Bob's study that were analyzed, and certainly an N of 252 must be statistically significant. Next. So the study design was used as an H&E staining or histology, along with scanning electron microscopy performed in the same similar region of the treatment area. There were thermal images that maintained surface temperature. The baseline, you can see on the left that the cell membranes are intact, and the SEM of the untreated adipose tissue showed intact cell membranes as well. 4 days post-treatment, you can see quite a bit of inflammatory change. The fat cells have lost diameter. There are cell membrane ruptures, and you can also see pycnotic nuclei. And the SEM, interestingly, shows great flattening of the adipocytes with quite a bit of loss of the cytosol internally. And this is something that is unrecoverable, and you're not going to see just in even in the regular treatment slides of traditional Emsculpt. So this is something that really amplifies the Emsculpt and makes the fat loss even greater. At 2 weeks post-treatment, you see a lot of small little lipid droplets in the SEM slides that are not really that visible on the histology of the adipose tissue. And the histology of the adipose tissue shows some ingrowth of collagen, those little pink strands that you're not really seeing quite as well on the SEM. So these are really complementary evaluations to do side by side. At 2 weeks post-treatment, you will see thousands of small lipid droplets interspersed with ruptured and damaged adipocytes. And of course, these are damaged beyond repair. At 1 month post-treatment, the histology shows that the ruptures in the membranes are still visible. And in the SEM, you can see that the inflammatory infiltrate is not quite as noticeable, but the damaged fat cells have not been cleared out by macrophages yet. At 2 months, you can see that the tissue is being basically normalized or restored in the SEM, and you can still see some stranding of collagen. This is not always a bad thing, because as we get older, the stroma of our adipose layer basically recedes, and you don't have that collagen support or framework that keeps the fat having a definite shape and having a firm feel. So restoration of that, or interspersement of the collagen framework, is actually beneficial for the stroma. Next. Interestingly, the adipocyte measurement decreases in a manner similar to that of cryolipolysis, but we'll show later the difference in that, because over time, the adipocyte diameter size in cryolipolysis goes totally back to normal, which of course shows a diminution of effect. And the diameter of cell size after the Emsculpt NEO retains a little bit of diminution. Temperature measurements in the subcutaneous tissue are maintained over a period of time throughout the treatment. And the conclusions of the SEM study showed that the adipocytes were damaged and or shrunk. There was a mild inflammatory response, and I think that this is really favorable in order to support the soft tissue that may have lost a framework of support over the years. Histology and SEM were parallel because they show the efficacy of the procedure for disruption of the adipocytes, which does not really happen with some of the other modalities. The procedure was safe, there were no superficial burns, and no other adverse events were documented. David Goldberg did a histology study that basically corroborated the results from Bob Weiss's study. His study design was 3 30-minute treatments once a week in 2 groups, the active and the sham treatment. So this is the first histology study that I know of that it actually had basically a totally controlled subject with 5% of the device output. So the design and evaluation included histology, continual temperature measurement just to make sure that the results were stable, waist circumference, and comfort and satisfaction. Here's our baseline again with no deviations in adipocyte shape or membrane disruption. And 1 week post-treatment, you can see some membrane disruption and pycnotic nuclei, which are indicative of apoptosis. And at 1 month, you can see some fragmentation of the cells on the right with more pycnotic nuclei. The adipocyte size, of course, was very different in the active group, and in the sham group, they stayed pretty much the same. There was really no real damage. Temperature in fat tissue was maintained over the duration of the treatment. And here's some photographic results. Here's a patient who's 57-year-old showing improved body contour, especially that periumbilical diastasis is better. Next. Waist circumference decreased by 2.2 centimeters. The sham patients had no change at all, and all the patients were comfortable. The active group, of course, was more satisfied with the results in the sham, and their scores were quite strong, as the sham group disagreed with any assertion that they had an improvement. So I think that there was no necrosis seen of the fat cells. If you have necrosis, and this is seen with, say, Kybella treatments, there's a whole lot of fibrosis, there's a whole lot of inflammation, And then you get some fibrotic or banding or scarring. So we want to avoid that. So this is a study that I, of course, have a special interest in because we're looking at muscle satellite cells and with the Emsculpt NEO, and have some really interesting histology on this study. So this basically was something studied looking for muscle-derived stem cells. Basically, these are responsible for myofiber development and renewal. And while you can get some myosatellite cells with exercise, the Emsculpt is shown in this study to generate quite a few more in a shorter period of time. So the objective of this study was to look at HIFEM induction of muscle hypertrophy and hyperplasia using the supramaximal contractions when combined with radiofrequency, and to see if this combination would improve the synergy and create a higher level of satellite cells. So this was 4 large white swine, 3 30-minute treatments once a week, as is per protocol. And the opposite side of the abdomen, or the non-treated side, was used as a control. We did 252 tissue slices in this study as well. I really like immunofluorescence because it really shows well the satellite cells as differentiated from the rest of the muscle cells. And for conventional histology, we used H&E stains. They were cut basically to 5 to 10 micrometers of thickness in both sections. And we used H&E stains, and one we used immunofluorescent stains. And the muscle temperature was monitored throughout the treatment and found to be stable. So with the immunofluorescence, we found a proportion of increase of myosatellite cells by 26.1% at day 4. This is a huge number. And at 2 weeks, the number was up to 30.2. And we saw this more by density than by new locations. And of course, no changes were seen for the control samples. And here's some early immunofluorescence after the baseline in the middle slide. And 2 weeks afterwards, you can see that the areas that show immunofluorescence are both more dense and larger as well. And in this area, you can see the level of satellite cells get bigger, and these myofibers are growing over time. So if we look at this with comparison to the exercise program, a 12-week exercise program in Mackey's study showed 36% satellite cell content, 90 days of exercise, 31%, 3 sessions of HIFEM once a week, 30.2%. So I think this compares very favorably with really high intensity exercise programs, especially those in males. If we look at Mackey's study in women, of course, it's much harder for ladies to gain muscle mass. Their response was only 18%. And so, of course, the HIFEM and RF was quite a bit more superior than any type of exercise in women. The histology showed some hypertrophic fibers, as well as signs of newly formed myofibers, and of course, no changes in healthy muscle structure were seen. There was no damage, and certainly no induced inflammation that you might otherwise expect. So if you look closely at these slides, they're very similar to the earlier porcine studies, showing a baseline musculature that's pretty similar to the first ones, and quite a bit of muscle hypertrophy at 2 weeks. And at 1 month, the muscles really filled out the muscle bundles. And in the next slide, you'll see some localized circles of really tiny. You can advance to the next one, Mike. The circles show little tiny areas of new muscle bundles, which indicate regions of satellite cell presence. Temperature measurements were consistent throughout the treatment duration, and muscle temperature got hot a little bit more quickly than fat. 2 minutes for muscle, and about 4 minutes for fat. So the conclusion of this study was that the increase of myosatellite cells was about 30.2% on average. And this is pretty comparable, especially in males, of 3 to 4 month exercise programs, and quite a bit better than you might see in females. So here's some case studies. Here's a male patient who had, I think, an incredible result done by Carolyn Jacob, a 34-year-old patient who had measured 14.1% improvement in muscle separation and 8.8% increase in muscle hypertrophy, as well as a 32% reduction in subcutaneous fat thickness. And a really nice result from Radina Denkova, 42-year-old patient who had 3 treatments administered, and her ultrasound results are pretty phenomenal. Quite a bit of fat reduction and muscle hypertrophy in this one. So this is probably one of my favorite slides because I think this problem in men is incredibly difficult to treat. There's not a good solution. You can do some liposuction, but a lot of this is also visceral fat. And he had a pretty incredible result 3 months after Emsculpt NEO. Here's another result by Bruce Katz showing, especially in the epigastric region, of really nice improvement in diastasis, as well as some significant fat reduction and quite a bit of muscle increase. And here's another patient by David Kent showing some pretty significant improvement in the abdominal protrusion that so troubles men. And even though theoretically diet and exercise is supposed to help men more than women, this is a problem that is difficult to improve, especially in the middle-aged man. So a review of the treatment protocol, 30-minute sessions. Even though most of the studies only used 3 treatment sessions 1 week apart, we're doing 4 treatments 5 to 10 days apart. For my patients, I do it once a week because it's easy to remember. And here's a part that's really interesting, comparison to other fat reduction modalities. I have a particular interest in the fat reduction efficacy when compared to cryolipolysis because I did a little mini study on this as well. And so while their publications show about an average of 22% fat reduction with cryolipolysis, remember that cryolipolysis really does nothing for the skin, and it certainly doesn't do anything for the underlying muscle. So while their data shows a significant decrease in fat measurement at 2 to 4 months post-treatment, we don't really have a lot of data showing long-term efficacy as we do even 6-month studies with the Emsculpt and Emsculpt NEO. The combination of RF and HIFEM, of course, is 30%. So here's my little mini study. And this was done maybe about 5 years ago. So I had a patient who had cryolipolysis just on one side. So we took a baseline SEM biopsy, and you can see the nice little biscuit-like adipocytes lined up neatly with no membrane disruption or deformity. At 1 month post-treatment, the biopsy showed folds in the cell from the crimping from the applicator and a little bit of fibrotic or neocollagenesis response. At 1 month post-treatment, you can see that this patient had a single damaged cell right in the center. There was a little bit of membrane damage, probably from the massage that the treatment people are induced to give a little bit of massage to break up the cells and cause a little more damage. But there's really nothing that shows cell membrane disruption or anything similar to that of the Emsculpt NEO. And so if we're looking at the measurement of the diameter of the Emsculpt versus cryolipolysis, The cryolipolysis results at 1 month show quite a bit of reduction in diameter of the cells. And if you look right in the center, you can see some really tiny little adipocytes. So the mechanism of action, and you can see a lot of lipid droplets in this SEM. So the mechanism of action of cryolipolysis is temporary egress of the triglycerides and free fatty acids, but no cell disruption whatsoever. And 3 months post-treatment, you can see quite a bit of fibrotic or collagen response. But again, now all of these cells are quite a bit bigger, and they have returned to about their 100 micron average diameter. So I think this is what we see when patients come in and tell you, well, I had cryolipolysis and I paid a lot of money for it, and it looked good for a while, but then all my fat came back. And this is why. So fat reduction when compared with cryolipolysis, their weighted average was about 22%. Weighted average for Emsculpt NEO is about 30%. And the Emsculpt NEO results last a little bit longer than the cryolipolysis results do. So the overview, this is, I think, a really good take-home slide. Radiofrequency and HIFEM or Emsculpt NEO, just under 30% average fat reduction per patient. Cryolipolysis weighs in at 22.4%, but I think this is more of a temporary thing than a long-term thing. And Emsculpt alone, 19.6%. External radiofrequency, 18.6%. Lasers, maybe 15. I haven't really seen that much. And HIFU lags behind at about 12.3%. So here's some other BTL products that I think are really great and go hand in hand with the Emsculpt NEO. My personal favorite of these is Emtone because it does great things for skin, not only cellulite. So I'd have to tell you, when I was looking at getting the Emtone, looked on the website and I thought, these results can't possibly be true. They have to be photoshopped. So I was really pretty skeptical. Next slide. And so in looking at cellulite, we know there are a lot of devices and treatments out there for cellulite, including Subcision, Selfina, etc. We're looking at correcting the enlarged fat chambers, the dermal laxity, fat hypertrophy, poor blood flow, and metabolic waste accumulation. So how does Emtone work? It gives mechanical stimulation, and it disrupts those rigid collagen fibers that tether in and create the divots. It stimulates new dermal collagen. You get partial shrinkage of the collagen triple helix, but you can also get fibroblast proliferation and get actual thickening of the dermis, which is something that you don't see too often in any other device. Next. This is a real synergistic result and effect. A lot of causes of cellulite can be improved, say with Selfina, which is mostly subcision, or you can do mechanical subcision. I had a cellulase that I still own and I can't get rid of, which was quite expensive, and it didn't really get nearly the results that the Emtone does. You see an increase in collagen, an increase in elastin, and a 44% measured increase in thickness of dermis. You get homogeneous heating with Emtone, especially if you have a trained applicator. My MAs are great at this. Next. And so some clinical studies, my good friend Klaus Fritz has a couple of these. You can see the links in cosmetic dermatology as well as